Welcome to Deep Dive Ortho, the show where we really get into the nuts and bolts of orthopedic practice. Today, we're looking at something you'll see almost daily in any pediatric A&E or clinic here in the UK, a child who's had a full suspected forearm fracture. These injuries are just incredibly common, aren't they? They make up a huge part of our workload. And really understanding the care, the details, the nuances is just so vital for looking after these kids properly. But also, for how our systems run efficiently. We're zooming in today specifically on pediatric distal forearm fractures, especially Greenstick and Torus or buckle fractures as they're often called. Now, they might seem pretty straightforward, routine even, but actually the way we diagnose and manage them is constantly evolving. There's a lot of new evidence coming through that can really shift how we approach things. Now, to help us navigate all this, we're really fortunate to have Prof. Mo Imam with us today, an esteemed expert in orthopedics, known for making sense of complex clinical information and really connecting the dots for professionals like yourselves listening in.
Thank you. It's great to be here. It is one of those topics, isn't it? Seems every day, but the science behind it, the practice, it keeps moving forward in really quite fascinating ways that can genuinely refine what we do day to day.
Absolutely. So our mission, if you like, for this deep dive is to give you a shortcut, to get you really well informed on these very common fractures. We'll dig into the epidemiology, look closely at the latest diagnostic tools, and really assess how effective different treatments are, including some quite novel approaches that are changing how we manage these injuries. So let's start right at the beginning. When we talk about fractures in children, it's not just a case of smaller adult bones, is it?
No, absolutely not. That's a crucial starting point.
Could you maybe unpack for us those fundamental differences between adult and kid skeletons and how the unique makeup of a child's growing bone, especially that open physis, shapes the fracture patterns we actually see?
Yes, that's exactly the right place to begin. A child's skeleton isn't just a miniature adult version, it's biologically quite distinct. The key difference, really, is in the bone's composition and, critically, the presence of that open physis, the growth plate. You see, pediatric bone has a higher proportion of collagen matrix, and the cross-links within that matrix are, more immature. This specific biochemical makeup gives it what we describe as a plastic in vivo mechanical behavior.
Plastic behavior.
Exactly. In simpler terms, adult bone tends to be more brittle. Under stress, it often snaps cleanly, rather like a dry twig.
Right.
A child's bone, on the other hand, is much more flexible. It can actually bend quite significantly, deform before it fractures completely. Think of bending a young green branch. It splinters on one side, but often stays connected on the other.
That's a great analogy, the green twig.
It is. And that inherent flexibility is precisely why we see fracture patterns in children, like the greenstick fracture, that are very rare or simply don't occur in adults once the skeleton has matured. This plasticity directly influences the types of injuries and how they heal.
That really clarifies it. So the key insight for everyone listening is that children's bones are fundamentally more flexible, more bendable, which completely changes how they break and heal compared to adults. What about the physis itself, the growth plate? How does that structure influence things?
The physis. It's absolutely critical. It's this cartilaginous structure that drives longitudinal bone growth through a process called endochondral ossification. It's organized into 4 distinct zones: reserve, proliferation, hypertrophy, and calcification.
And those zones matter because?
Well, they matter for a couple of key reasons. Firstly, the hypertrophic zone is structurally weaker than the others. It's often the point that fails under stress, a sort of weak link in the growing bone. Secondly, whilst the surrounding bone, the periosteum, metaphysis, diaphysis, is quite strong, an injury to the physis itself can have really significant long-term consequences if it's severe or isn't managed properly.
Because of the growth implications.
Precisely. The blood supply for that longitudinal growth comes via the epiphysis. Damage the physis, and you risk disrupting that blood supply. This can potentially lead to slowed bone growth, angular deformities developing over time, or even differences in limb length. All things that need careful monitoring and management long after the initial fracture has healed. So it's not just about the break, it's about protecting future growth.
That really links the biology directly to the clinical importance. So given these unique properties, let's define the specific incomplete fractures we're focusing on. Greenstick and Torus, or buckle fractures. Could you walk us through their defining features and maybe highlight the key differences that guide our initial management?
Certainly. These two are the absolute classic pediatric fractures, stemming directly from those bone properties we've just discussed. So, greenstick fractures first. As the name implies, they're partial thickness. The cortex, the hard outer layer, and the periosteum covering it are broken on one side, but they stay intact on the other side.
Like that green twig analogy again.
Exactly that. It breaks on the tension side, but the compression side just bends. Very common, typically in children under 10. On an X-ray, you'll see that bending, a fracture line that doesn't go all the way through, disruption on the tension side, and often that plastic deformation, that bowing, on the opposite side. Then you have torus, or buckle, fractures. These are compression injuries. The cortex essentially wrinkles or buckles under the force, usually at the metaphysis, that slightly wider bit near the joint, but critically, there's no actual break through the cortex.
Just a buckle, literally.
Just a buckle, often from axial loading, like falling onto an outstretched hand. These are probably the most common fractures we see in children overall, especially around the wrist.
Okay, that's very clear. So what is the absolute key difference between them when we think about stability? And why does that distinction matter so much right at the start?
Stability is the crucial difference. Greenstick fractures are inherently less stable than buckle fractures. They have the potential to displace further, even after you've initially reduced them or put them in a cast. That means they generally need more careful follow-up. Buckle fractures, though, they are stable injuries. Once they've buckled, they rarely move further.
That makes sense.
And I should probably just briefly mention plastic bending deformities, too. That's where the bone actually bows or curves permanently without a clear fracture line visible. We still treat these like fractures as they need support to straighten out. And then, of course, you have complete fractures, transverse, comminuted, oblique, where the bone breaks right through. They're much less stable, usually need more involved treatment, and we tend to see them more in older children or adolescents as their bones become a bit more brittle, a bit more adult-like. So classifying correctly right at the beginning really dictates the whole pathway.
It's just incredible how common these are. Given those definitions, what does the epidemiology tell us? What's the sheer scale of this? What are the key numbers that shape how we think about pediatric forearm injuries, not just for one patient, but for the NHS, for resource planning?
The numbers really do highlight the scale. Pediatric distal forearm fractures are incredibly common. A major population-based study from 2022 put the overall incidence at around 738 per 100,000 persons per year.
That sounds like a lot.
It is. To put it in perspective, they account for nearly 18% of all pediatric fractures turning up in A&E departments in the U.S. And here in the UK, wrist and forearm fractures alone make up about half of all fractures seen in children. We're talking hundreds of thousands of cases every year, which obviously demand significant resources.
A massive volume indeed. Are there particular patterns, specific age groups or sexes more affected? Does that help us plan?
Yes, there are definite peaks. For girls, the incidence tends to peak around age 10, hitting about 1,578 per 100,000 per year. For boys, the peak is a bit later, around age 13, and even higher, roughly 1,704 per 100,000 per year.
Wow.
Think about that nearly 2% of all 13-year-old boys will break their forearm each year. It's remarkable. Now, whilst greenstick fractures specifically seem to have a fairly equal incidence between boys and girls, overall, boys are generally more likely to sustain any type of fracture during childhood, probably due to, well, differences in activity levels and risk-taking behavior. Understanding these demographics definitely helps with planning services and perhaps even prevention efforts.
And location within the forearm. And the mechanism, how do these typically happen?
Distal fractures, so nearer the wrist, are much, much more common than proximal ones nearer the elbow. Within those distal injuries, the ulnar styloid, that little bony lump on the pinky side of the wrist, is the most common intra-articular injury site involved in about 80% of those cases. As for how they happen, overwhelmingly, it's a fall onto an outstretched hand. The classic faux injury, FOOS.
The foosh.
Often there's a rotational element, too. A child falls, instinctively puts their hands out, often pronated. The impact hits the hand, forces the forearm to bend dorsally, often into supination, and that's when the bone gives way. While falls are number one, we always have to consider other causes, road traffic collisions, sports injuries. And critically, especially with younger children or if the story just doesn't quite fit the injury, we must always keep non-accidental injury, NAI, in the back of our minds. That suspicion is a crucial part of the assessment.
Absolutely essential. And beyond the trauma itself, are there underlying risk factors?
Yeah.
Things that might make a child's bones more susceptible?
Yes, potentially. While the trauma is the event, certain underlying factors can increase risk. Malnutrition, for example, particularly vitamin D deficiency, has been linked to an increased risk of greenstick fractures after trauma. It just highlights the broader picture, doesn't it? The importance of general pediatric health and nutrition for bone strength. Sometimes our role goes beyond just fixing the break to considering the child's overall health context.
Right, so let's picture the scene. A child comes into A&E, you suspect a forearm fracture. What are the absolute must-check clinical signs, and what's the kind of systematic examination pathway you'd advise to make sure we don't miss anything crucial?
Okay, the initial assessment is fundamental. Obvious things we look for are pain, bruising, tenderness when you gently feel along the bone, visible swelling. Sometimes, thankfully, it's obvious there's a clear bend or twist in the arm. But the immediate priority always is neurovascular status. You absolutely have to check sensation, capillary refill in the fingers, the general warmth and color of the hand, and crucially, muscle function. Can they move all their fingers properly? Any pins and needles?
Essential first steps.
Absolutely. Then you must systematically examine the joints above and below the injury, the elbow and the wrist. This is vital for picking up any hidden fractures or associated injuries like Monteggia or Galeazzi fracture dislocations. These can be subtle sometimes, but have major long-term consequences if missed.
And how does the child's age affect things?
Profoundly. A younger child might not say, "My arm hurts here." Instead, they might just refuse to use the arm at all or be crying inconsolably. An infant presenting after a fall needs a different approach to a teenager. So, say a 7-year-old falls in the playground. We'd be meticulously checking for point tenderness along the radius and ulna, assessing that full neurovascular function, even if visually the arm looks okay. And again, particularly in the very young, or if the story seems inconsistent, that possibility of non-accidental injury must always be considered. Thoroughness and sensitivity are key.
Okay. X-rays, of course, are the traditional gold standard. But you mentioned these incomplete fractures can sometimes be subtle. Are there newer tools or alternatives coming through, especially for tricky greenstick or buckle fractures?
X-rays are definitely still the cornerstone. For a green stick, we're looking for that bend, the break only on one side, maybe some plastic deformation on the other. For a buckle, it's that compression wrinkle without a clear break line. Standard AP and lateral views usually do the job initially, but, and this is a really exciting development, point-of-care ultrasound is rapidly emerging as a powerful tool here.
Ultrasound for fractures.
Yes. Significant recent studies have clearly shown it's highly effective and very sensitive for diagnosing these specific types of fractures. The advantages, especially in pediatrics, are really compelling.
Such as?
Well, first, it's radiation-free. That's a huge plus for children. Second, it can often be less painful during the examination, as you might not need to manipulate the limb as much to get the views. And third, it's quick. You get results right there at the bedside or in clinic, allowing for faster decisions.
That radiation-free aspect is definitely appealing. Can you say a bit more about the evidence for its sensitivity compared to X-ray for these perhaps less obvious breaks?
Indeed. One particularly strong study looked specifically at undisplaced greenstick and Torus fractures of the distal radius. The results were quite striking. It found ultrasound was actually more sensitive than X-rays for these injuries.
More sensitive.
Yes. In that study, all 79 fractures they looked at were clearly seen on ultrasound, often as a little dark line, a hypoechoic zone, through the cortex. But 4 of those same fractures were actually missed on the initial X-rays.
4 missed on X-ray but picked up on ultrasound. That's significant.
It really is. It suggests ultrasound might be better at picking up these very subtle cortical disruptions. So while X-ray remains vital for the overall picture, assessing alignment, confirming things, the role of ultrasound is definitely expanding. It's a fantastic, radiation-free, sensitive option, especially for these common, often subtle distal forearm fractures in the acute setting. Of course, for very complex cases, or if we're planning surgery, we might still need MRI or CT for detailed 3D views, but they aren't the first port of call for typical green sticks or buckles.
It really sounds like getting that classification right, green stick, buckle, complete even for subtle ones, is absolutely vital. Why is pinning down that exact fracture type so crucial for what we do next, for the management plan?
It's fundamental, really. It's the linchpin for the whole management pathway. Why? Because it tells us directly about the inherent stability of that fracture. And that stability dictates how much intervention, how much follow-up is actually needed. As we've said, buckle fractures, stable. Green stick fractures, unstable. Risk of further displacement. Complete fractures, highly unstable.
So getting it right at the start means...
It means we can immediately triage patients appropriately. We can identify the group who genuinely need closer monitoring, maybe repeat X-rays, multiple clinic visits, versus those who can be managed much more simply, perhaps even discharged from A&E with advice. This isn't just about optimizing the outcome for the individual child, ensuring they heal correctly. It's also incredibly important for streamlining care pathways. Reducing unnecessary follow-ups for stable injuries makes a huge difference to clinic workloads, to NHS resources. It allows us to focus those resources on the patients who truly need them most. It's about doing the right thing for the right patient efficiently.
That clarity on classification takes us neatly into treatment. So let's unpack the goals here. When we talk about reducing a pediatric forearm fracture, what actually defines a correct reduction in a child? And how does that amazing remodeling potential we talked about influence our decisions?
Right, the goals in pediatrics are slightly different from adults. We're not always aiming for absolute anatomical perfection on the X-ray. The primary objective is restoring excellent function, especially that critical forearm rotation, pronation, and supination. Normal ranges are roughly 71 degrees pronation, 84 degrees supination. Now, an adult might function perfectly well with, say, 50 degrees of each, but in a child, we ideally want to preserve that full range for their long-term development and activities.
And the remodeling helps achieve that, even if the reduction isn't perfect.
Exactly. This is where the magic of pediatric bone comes in. Children's bones have this incredible capacity to remodel, to straighten themselves out over time. This is especially true for fractures near the growth plates, like distal forearm fractures, because of the high activity of the growth plate itself and the very active periosteum surrounding the bone. So what this means in practice is that a perfect anatomical reduction isn't always essential. However, and this is crucial, the alignment must fall within certain acceptable parameters. These parameters are generally age-dependent.
So there are specific guidelines for what's acceptable, rather than just aiming for straight. That must be different from adult fracture care.
Precisely. We rely on well-established guidelines, like those from Noonan and Price. These give us age-specific criteria for things like acceptable angulation, rotation, and even bayonet apposition where the bones overlap slightly. For example, in younger children, say under 9 or 10, the guidelines often stratify by sex slightly differently. An angulation of less than 15 degrees might be perfectly fine. Rotation less than 45 degrees too. But for older children, closer to skeletal maturity, their remodeling potential is less, so the thresholds become much stricter. Maybe less than 10 degrees angulation is needed. Bayonet apposition up to a centimeter can also be acceptable in the young ones.
That's really useful to quantify.
It is. Imagine explaining to a parent looking at their 6-year-old's X-ray showing a slight bend. We can say, look, it's not perfectly straight now, but because they're young, their bone has this amazing ability to remodel. Over the next year or two, it will very likely straighten itself out as it grows. These guidelines give us the evidence base to know when conservative management is enough.
That's incredibly reassuring. So, when a greenstick fracture does need a reduction, what are the techniques? Especially thinking about that tricky rotational part.
For greenstick fractures needing closed reduction, meaning without surgery, the technique often follows Evans' theory. It's about reversing the force that caused the break. So if the fracture has apex volar angulation bent towards the palm side, usually from a fallen supination, you'd pronate the forearm during reduction. If it's apex dorsal bent towards the back of the hand, usually from a pronation force, you'd supinate it. Then you immobilize it in the position that holds that reduction.
And you need to actually complete the fracture, break the other side. I seem to remember that being discussed.
That's an interesting historical point. Older teaching sometimes did advocate deliberately breaking the intact cortex to get a more anatomical reduction, but modern thinking has shifted. The focus now is on achieving that acceptable alignment based on the remodeling potential, usually without needing to complete the fracture. We achieve it through careful manipulation, usually traction, to pull the bones apart slightly, then correcting the angulation, and finally that crucial rotational maneuver to line things up. The aim is acceptable alignment and stability for healing, not necessarily X-ray perfection.
Right. Once it's reduced acceptably, what are the options for holding it there? Immobilization. What's the evidence say about cast versus other things and how it affects the child's life?
Immobilization choice depends a lot on the fracture type and stability. The traditional workhorse for greensticks is, of course, casting a plaster or fiberglass cast. Duration is typically 6 to 8 weeks for a greenstick, maybe a bit longer, 8 to 10 weeks in older children. Distal fractures often just need a short arm cast below the elbow. More proximal ones might need a long arm cast above the elbow, sometimes changed to a short arm cast partway through. Complete fractures usually get a long arm cast, elbow bent to 90 degrees for maximum stability.
And getting the cast right is important.
Absolutely vital. Proper molding is key. We need good three-point fixation. That often involves anterior and posterior compression over the interosseous membrane between the bones and careful medial-lateral molding, perhaps above the elbow condyles in a long arm cast, to stop it slipping. We even look at the cast index. The cast's shape, a flatter cast, a higher index, is more likely to let the fracture slip. While pasting works, it does have downsides. Temporary stiffness, some muscle wasting, skin issues sometimes. Stiffness usually gets better quickly once the cast is off, especially in younger kids, but it can be more of an issue in adolescents. Moving on from casts, splinting is an option too, especially for minimally angulated green sticks in younger children, maybe under 9. A removable splint is often less costly and much more convenient for things like washing.
Less rigid, though.
Less rigid, yes. But for selected stable or minimally angulated cases, studies show it can provide enough support for healing without increasing pain or deformity risk.
Oh.
But here's where things get really interesting, and practice is genuinely changing based on strong evidence. Tubi grip.
Just a bandage.
Essentially, yes. For undisplaced greenstick and Torus fractures of the distal radius, the evidence for using just a simple Tubi grip bandage is incredibly compelling now. A major randomized study compared Tubi grip to traditional rigid splints or casts for these injuries. The findings were clear. Tubi grip was superior. Less interference with the child's daily life, less stiffness, better grip strength recovery, and crucially, absolutely no difference in pain scores, need for painkillers, or risk of the fracture displacing or healing badly.
That really is a game changer for day-to-day practice. It challenges that instinct to put everything in a rigid cast. So what's the single biggest takeaway for someone managing these stable fractures in clinic tomorrow? It sounds like it simplifies life hugely.
The biggest takeaway is exactly that. For these specific stable fractures, undisplaced green sticks and Torus fractures at the wrist, less is demonstrably more. Tubi grip means far less disruption for the child and family. Less time off school, easier to manage personal hygiene, quicker return to function without the hassle and discomfort of a cast. And from a system point of view, it massively cuts down on follow-up appointments, frees up clinic time, reduces costs. It fits perfectly with this wider move towards early functional treatment for stable fractures in children, which often gives better results than prolonged rigid immobilization. It's proper evidence-based de-escalation of treatment.
We've talked treatments, but what about the patient's part in all this? How much does compliance matter? And what can we learn from those tricky cases where things go wrong, maybe re-injury?
Oh, compliance is absolutely critical. Our clinical experience strongly backs this up. We often see that even small increases in deformity, sometimes less than 5 degrees you might notice, clinically happen in patients who haven't quite followed the advice. These are often the more energetic kids, aren't they? The ones desperate to get back on your skateboard, their bike, their trampoline, maybe before healing is complete.
So it's not the fracture inherently slipping, but new trauma.
Very often, yes. What's really key to get across to families is that it's usually re-injury rather than the original fracture just being unstable and collapsing that causes further problems or deformation, especially once they're out of the initial rigid immobilization or if they were treated with something less rigid like a splint or Tubi grip. I remember one case vividly, a young lad in a plaster cast for his forearm, but his parents were finding compliance tricky. Turns out he was using his cast arm as a sort of club during rough play. Unsurprisingly, that led to further deformation. It really highlights that while the cast or splint offers protection, the arm is still vulnerable. Patients and families need clear education about activity restrictions, safe play, and protecting the arm throughout that healing period, regardless of the immobilization method. Our advice is just as important as the plaster itself.
Okay, so conservative management is clearly key for many within those guidelines. But what about surgery? What's the evidence saying about the trend? Are we operating more on these fractures now, and if so, why?
Yes, there's absolutely no doubt we are seeing a clear and significant trend towards more surgical intervention for pediatric forearm fractures. The data backs this up consistently over the last couple of decades. One review pointed to a 7-fold increase over a period. Another study from Finland showed a 62% rise in surgical treatment just between 1997 and 2006. And in the U.S., the proportion of these fractures treated surgically went from just under 60% in 2000 to 70% by 2012. So yes, a definite shift.
That's a pretty dramatic increase. What do you think is driving that? Is it purely clinical need, or are other factors involved?
It's likely a mix of things. Certainly, advances in surgical tech, better implants, safer techniques like elastic nailing play a part. Surgery has become perhaps less daunting. But I suspect there's also a change in expectations. Possibly a lower tolerance for any residual deformity, both from families and maybe from surgeons too. There's perhaps more pressure now for that perfect anatomical result, a quicker return to sport and full function. So injuries that might have been managed conservatively in the past, accepting some remodeling, are maybe more likely to be considered for surgery today. The trend also strongly correlates with age. Very young children are rarely operated on, whilst adolescents with much less remodeling potential left are operated on far more frequently.
So given that shift, when do we actually cross that line? When do we say, okay, conservative isn't going to cut it, we need to operate? What are the clear indications, the red flags?
The decision for surgery usually comes when we either can't get an acceptable reduction by manipulating the fracture, or just as importantly, we can't keep it reduced with a cast or splint. So the main sort of non-negotiable indications. Unstable fractures that are irreducible. That might mean significant displacement you just can't correct, or maybe severe shortening with overlap, or persistent malrotation despite trying to reduce it.
Okay.
Other clear triggers for surgery would be refracturing through the same spot, open fractures where the bones come through the skin that needs cleaning out and stabilizing. Any fracture with nerve or vessel damage needs urgent attention, often surgical. Pathological fractures where there's an underlying bone problem like a cyst. And complex injuries like a floating elbow where you have both forearm and humerus fractures.
Are there factors that predict needing surgery earlier?
Yes, we look for predictors of likely failure of conservative treatment. Being 10 years or older is one. Having a fracture in the proximal third of the radius is another. And certain fracture patterns, like having an ulna fracture angle less than 15 degrees. These groups might warrant earlier consideration for surgery, but again, age and remodeling potential are huge factors. Under 9, we lean heavily towards conservative if possible because they remodel so well. Older kids, adolescents with maybe less than a couple of years of growth left, we're much stricter. Angulation over 10 degrees mid-shaft, or 15 degrees distally, or rotation over 30 degrees, or significant overlap. Surgery becomes a much stronger consideration because they won't remodel it away. It's always a balance of risks and benefits against that remaining growth.
That gives a really clear framework. So if a surgery is the answer, what are the main techniques? What are the options for fixing these fractures? And what are the pros and cons, the nuances of each?
Broadly, there are 3 main surgical options we use. Elastic stable intramedullary nailing, or ESIN, traditional plating, and a newer approach, hybrid fixation. ESIN is definitely the most common worldwide right now. It probably accounts for up to 80% of surgically treated forearm fractures.
80%, that's huge.
It is. And the reasons are clear. It's minimally invasive, small incisions, better cosmetically. That usually means shorter anesthetic time, shorter hospital stay. It provides good stable alignment while things heal. It works for both closed and open fractures. And importantly, the nails are relatively easy to take out later. Technique-wise, we usually put the nail in the radius from the top-down antegrade and in the ulna from the bottom-up retrograde. Often do the ulna first, it's a bit straighter. The nail diameter is chosen carefully, usually about 40% of the width of the marrow cavity, to provide stability but still allow some flexibility.
You mentioned before there's some debate about fixing just one bone versus both bones with ESIN. Can you expand on that? What are the practical thoughts there?
Yes, that's an ongoing discussion. Some studies suggest being cautious with fixing only one bone, citing a risk of the other bone, or even the fixed one, gradually bending or deforming over time. They'd argue for fixing both bones if possible, especially aiming to restore that crucial curve, the bow, in the radius.
But others disagree.
Others have found no significant difference in the final functional outcome or complication rates whether you fix one bone or both, so practically. Single bone fixation might be perfectly reasonable in younger children with lots of remodeling potential, maybe with more distal fractures, or if one fracture is very stable, like a Greenstick, and the other needs fixing. It really depends on the exact fracture pattern, the child's age, and the surgeon's experience and judgment call in that specific situation. No single right answer for all cases. We do need to be aware of complications with ES, though. The overall rate is somewhere between 17% and 42%, so it's not insignificant. You can get local problems, infection at the insertion site, skin irritation from the nail ends. More seriously, though less common, are things like tendon irritation or even rupture the thumb extensor, EPL, can sometimes rub on a prominent radial nail end. Nerve injury is possible, nails can migrate, you can get bursitis, prominent scars, or rarely synostosis where the two bones abnormally fuse together. Refracture after the nails come out is a risk too, especially if they're removed too early. We generally like to wait at least 6 months, ideally until full healing is seen. And compartment syndrome, whilst rare, is a devastating complication we always watch for. Risk is higher with longer surgery, open fractures, or operating very soon after the injury.
Okay, lots to consider there. What about the other main option, plating? When would you choose that, and how does it compare?
Plating, opening the fracture site and fixing it with a metal plate and screws, is another really important tool. It's often indicated for more complex situations. Think comminuted fractures, where the bone's in multiple pieces, fractures right at the apex of the radial bow, fractures involving the joint surface, or perhaps if conservative treatment has failed and the bone has displaced late. It's also often preferred in skeletally mature adolescents, where precise anatomical alignment is more critical as they won't remodel.
What are the advantages of plating?
The big advantage is you get direct visualization. You can achieve a really precise anatomical reduction, correct rotation perfectly, and restore that radial bow accurately. This often allows for earlier mobilization, getting the wrist and elbow moving sooner.
Disadvantages.
It's inherently more invasive. You need a bigger incision, more soft tissue dissection, stripping the periosteum off the bone to get the plate on, which theoretically could affect blood supply and healing, though often doesn't cause major issues. We typically use specific plates, like a third tubular or a 2.4 millimeter compression plate, long enough to get good fixation with usually at least 3 screws on either side of the fracture. Complication rates for plating are roughly similar to ESIN, maybe 16.5% to 33%. Risks include non-union, the bone not healing, or malunion healing crooked. Nerve damage is a risk, perhaps slightly higher for the ulna due to the nerve's proximity. Scar issues, infection, hardware problems, refracture are all possible. Whether to remove the plates later is another debated topic. Some evidence suggests leaving them in doesn't increase refracture risk, so removal is often just for specific problems like pain or irritation.
And briefly, that hybrid fixation approach you mentioned, was the thinking there?
Hybrid fixation is where you combine the two techniques. Typically, that means using ESIN for the radius and a plate for the ulna.
Why would you do that?
The idea is to get the best of both worlds. Use the nail to preserve the radial bow in a minimally invasive way, but use the plate on the ulna perhaps for better rotational control, or because plating might have a lower non-union rate for the ulna compared to nailing in some studies. Some studies suggest it's safe and effective, particularly for older children, maybe 10, 16 years old. It might reduce issues like delayed healing of the ulna and maybe speed up overall union time. Complications can still happen, of course, but it's another option in the toolbox, aiming to leverage the strengths of both nailing and plating for tricky fractures.
So with these different options, ESN, plating, hybrid, how do surgeons actually choose? Is there a clear winner, or is it more tailored?
That really is the million-dollar question, and the honest answer is there's no single consensus from the literature saying one is definitively best overall. Most modern studies show pretty similar functional outcomes and complication rates between plating and nailing when you look at large groups.
So it comes down to specifics.
Exactly. In practice, ESIN is often the go-to for simpler fracture patterns. It's quicker, less invasive, better cosmetically, easier hardware removal. Plating definitely still has a vital role for the more complex injuries comminuted, articular, maybe in older adolescents, where some studies suggest plating might have fewer major complications for complete fractures. So the best choice really depends on that individual assessment. The child's age, how much growth they have left, the exact fracture pattern and stability, and importantly, the surgeon's own experience and comfort level with each technique. It means we constantly need to evaluate the evidence, the technologies, and tailor the treatment to that specific child in front of us.
Moving beyond the immediate treatment, what about the longer term? Especially thinking about stability and how much follow-up is actually needed. You stressed earlier that buckle and greenstick fractures behave quite differently. How does that play out afterwards?
Yes, this is incredibly important for how we run our services efficiently and effectively. Let's reinforce that. Buckle fractures are stable, they heal well, they rarely cause problems, and generally they don't need prolonged or intensive follow-up. We can often discharge these patients fairly quickly with reassurance. Greenstick fractures, though, they are unstable. There's that inherent risk they could displace further, even in a cast. So they traditionally require more careful monitoring, often repeat x-rays, more clinic visits. Complete fractures, naturally, being the most unstable, need the most rigorous follow-up.
But does all that traditional follow-up actually achieve much?
Well, this is where it gets really interesting and frankly challenges how we've traditionally done things. Some quite eye-opening studies have looked back at routine follow-up for these common fractures. One found that only 1 in 311 follow-up appointments actually led to any change in management.
1 in 300.
Yes. A tiny fraction. It really makes you stop and think, doesn't it? Are we potentially over-monitoring, bringing children and families back to busy clinics for appointments that, in the vast majority of cases for stable fractures, don't change anything? It certainly raises questions about resource use and patient convenience.
That statistic is startling. It definitely suggests room for improvement. How are newer ideas like direct discharge and virtual fracture clinics tackling this over-monitoring issue, especially for the common, less complex fractures?
This is a really positive area of change driven by needing to improve patient experience and make our healthcare systems more efficient, without compromising safety, of course. Direct discharge DDE protocols are specifically designed to cut down on those routine outpatient follow-ups for low-risk injuries, like isolated buccal fractures or even stable undisplaced greenstick fractures at the wrist.
How does direct discharge work in practice?
Instead of automatically booking a fracture clinic appointment, the child is discharged directly from A&E. They'll get their brace, or maybe just a 2B grip as we discussed earlier, and crucially, very clear, comprehensive information. This is often provided via leaflets, sometimes even smartphone apps now, explaining the injury, expected recovery, warning signs, and importantly, giving them a direct helpline number they can call if they have any worries or questions during recovery. It empowers families to manage things at home, knowing support is easily accessible if needed.
And is it safe? What's the evidence say about outcomes compared to the old way?
The evidence is very strong and reassuring. A recent large study, published in 2024, with over 270 children, compared DD directly with traditional follow-up for both Greenstick and Torus fractures. It found DD was non-inferior, meaning just as good in terms of patient and parent satisfaction. Critically, functional outcomes were comparable, and there were no observed complications, so safety wasn't compromised. And here's the key bit for the system. It resulted in a statistically significant reduction in healthcare use, saving on average between 1 and 1.17 follow-up appointments per patient. That makes DB a fantastic solution for stretched orthopedic services, freeing up capacity for more complex cases.
And specifically for buccal fractures.
For buccal fractures, the evidence is now so compelling that many centers are moving towards minimal follow-up, often just immobilization in a removable splint or 2B grip, and then either no face-to-face review at all, or perhaps a virtual fracture clinic review where things are checked remotely. The risk of anything going wrong is just so incredibly low. In fact, there's an ongoing trial called the FORCE trial, which is looking at whether even just a soft bandage is enough for these ultra-stable Torus fractures. It really shows a major shift towards minimalist, patient-friendly care for these low-risk injuries.
That's fascinating progress. Now, while forearm fractures are common, you sometimes see greenstick fractures elsewhere that pose unique problems, like the proximal tibia near the knee. Could you tell us about the challenge of post-traumatic tibia valga?
Yes, that's a good example of how the same fracture type can behave differently depending on location. Proximal tibia fractures in children are rare, maybe 5 or 6 per 100,000 per year. But the tricky thing is that after these fractures, particularly greenstick ones, we often see a gradual development of valgus deformity. The lower leg starts to angle outwards from the knee. And this can happen whether we treat it conservatively or surgically.
Why does that happen?
The exact reason, the pathogenesis, is still debated. Theories include bits of soft tissue getting trapped in the fracture site, stimulating uneven growth, altered blood flow to the growth plate, causing the inner side to grow faster, maybe even a subtle injury to the outer part of the growth plate slowing its growth, or perhaps it's related to pre-existing alignment. It's complex.
So what happens when we treat them? Does surgery prevent this valgus drift?
Well, a recent important multi-center study looked at exactly this, and the findings were quite revealing, perhaps slightly counterintuitive. They found that this progressive valgus deformity happened in both the non-surgically and the surgically treated groups. In the non-surgical group, the angle, the MPTA, did increase statistically, meaning it got more valgus on X-ray, but importantly, it wasn't usually a clinically significant change for the child.
And the surgical group?
More surprisingly, in the group treated with surgery, while the angle initially improved slightly with the operation, it then actually increased again, becoming more valgus after the metalwork was removed. We don't fully understand why that happens post-removal, maybe rebound growth stimulation.
Because the implication is?
The key clinical implication is that surgery for these proximal tibia greenstick fractures seems to have a limited effect in preventing this valgus progression. It might only be justified in very select cases with severe initial deformity. If surgery is done, getting a perfect anatomical reduction and stable fixation seems crucial to try and minimize the drift. It's worth noting the study had relatively short follow-up, and sometimes this valgus can partially correct spontaneously over many years, but it remains a challenging area.
Finally then, looking long-term for the common forearm fractures, what should clinicians and families be aware of? Risk of refracture, other potential issues down the line. Most kids do well, but are there things to watch for?
Refracture is definitely a consideration, especially after greenstick fractures because of that inherent instability. If they aren't immobilized properly or for long enough, or if the child is very active too soon, that initial incomplete break can be a weak spot, leading to recurrent fractures. Another critical long-term factor is rotational alignment. Getting that right during the initial treatment is vital. We look for things like the radius crossover sign on X-rays to ensure the top and bottom ends of the radius are lined up correctly rotationally. If they heal with malrotation, it can cause a permanent loss of forearm rotation pronation and supination, which can really impact hand function for life.
But overall, the outlook is good.
Overall, yes, the prognosis for most greenstick and buckle fractures is excellent. The vast majority heal without any long-term functional problems or noticeable cosmetic issues. But consistent follow-up, tailored appropriately as we've discussed, is still needed to ensure healing progresses well and to catch any potential issues early. While most recover fully, it's worth remembering some studies suggest that even 10 years later, a small minority, maybe up to 19%, might still report some pain, about 5% might have slightly decreased movement, and around 9% might feel their overall recovery was only moderate or poor. This seems more likely in those who are older, over 10, at the time of injury, and perhaps those whose fractures healed with more significant angulation, say over 20 degrees. It just reminds us that even these simple fractures deserve careful initial management and appropriate follow-up to minimize that small group with longer-term symptoms.
Prof. Mo, that was an absolutely fantastic and incredibly thorough deep dive into pediatric distal forearm fractures. Thank you so much for guiding us through such a common yet clearly complex area of our practice.
It's been my pleasure. It's certainly a field that keeps evolving and always benefits from revisiting the evidence and refining our approach.
So just to quickly recap the key takeaways for everyone listening, we've covered the unique bend-don't-break nature of children's bones, the significant rise of ultrasound in diagnosis, the real shift towards less intervention for stable fractures, think tubing grip and direct discharge, and the carefully considered, though increasing, role for surgery like ESIN and plating. We also touched on challenges like tibia valga and the importance of long-term outcomes, especially rotation. This really underscores how pediatric fracture care is constantly evolving, driven by research aiming for better outcomes for kids, whilst also making our healthcare systems work smarter. It leaves you wondering, doesn't it? As our understanding of bone biology, healing, remodeling in children gets even deeper, what might future tech bring? Could we see even less reliance on rigid immobilization, perhaps biointegrative implants that actively help remodeling? Or maybe AI helping predict exactly who needs intervention and who will heal perfectly well on their own. The future possibilities are certainly intriguing. If you found this deep dive valuable, please do take a moment to rate and share our show with a colleague who might find these insights useful. Join us next time for another Deep Dive Ortho.